Good day, everyone. Today I am going to discuss about tracheostomy. First, to define tracheostomy, it refers to the creation of a communication between the trachea and the overlying skin. This may be done either by open or percutaneous technique. Tracheostomy is done for airway obstruction, respiratory support, pulmonary hygiene, elimination of dead space, and treatment of obstructive sleep apnea. It has no absolute contraindication. For its relative contraindication is when a discrete surgical access to the airway is the anticipation that blockage is laryngeal carcinoma. These are the following anatomical landmarks for tracheostomy. Thyroid notch, a palpable landmark to identify the superior aspect of the larynx in the midline. Cricothyroid membrane, a palpable depression between cricoid and thyroid cartilages. This is the location for an emergent cricothyrotomy. Cricoid cartilage, a palpable landmark to identify the junction of the larynx and trachea. Prepare the necessary instruments, which are the following: cotton with iodine, syringe with local anesthesia, scalpel, scissors, forceps, sutures, needle holders, retractors, tracheostomy tube, suctioning apparatus with a track tube tie. For the patient position, if no contraindication exists, the patient should be positioned with the neck in extension. This elevates the larynx and brings up to 50% of the proximal trachea into the neck. For the procedure, prior to proceeding, palpate and identify the hyoid, thyroid, and cricoid cartilages. A 2 to 3 cm incision should be marked at the approximate level of the tracheal ring to 1 cm below the cricoid. Sterilize the skin of the anterior neck and chest and drape the neck. Inject the local anesthesia. Make sure that it has taken effect before making an incision. For the skin incision, make a horizontal incision 1 finger breadth below the cricoid prominence. It is cosmetically preferable to a vertical midline incision. Extend the incision through a skin and subcutaneous tissue. For the infrahyoid strap muscles, dissect towards the trachea by parting the tissues with scissors, remaining strictly in the midline in a vertical plane to avoid injury to the inferior thyroid veins. Identify the midline cervical fascial plane between the sternohyoid muscles. Divide this intermuscular plane by spreading with a pair of scissors. The trachea and cricoid can now be palpated. The thyroid isthmus overlies the second or third tracheal rings, so retract the isthmus superiorly with Langenbach retractors to expose the trachea. Expose the infrathyroid trachea by carefully parting the overlying soft tissues with a pair of scissors, taking care not to tear the inferior thyroid veins. Ensure that the surgical field is completely dry before proceeding. To create a tracheostoma, create an inferiorly based flap raised from the anterior wall of the third and fourth tracheal rings. A silk traction suture is passed through this anterior tracheal flap and loosely secured to the skin. For the insertion of the tracheostomy tube, assess the size of the trachea and select the largest cuffed tracheostomy tube that comfortably fits the tracheal lumen. Inject air into the inflatable cuff of the tracheostomy tube to test the integrity of the cuff. Insert the introducer into the tracheostomy tube. Insert the tracheostomy tube into the tracheostomy under direct vision while applying traction to the silk traction suture attached to the tracheal flap. Ensure that the tube has been inserted into the tracheal lumen. Attach the anesthetic tubing. Hand ventilate while correct placement of the tube within trachea is confirmed by checking the expired PCO2, checking for chest movement, or listening to breath sounds. Securing the tracheostomy tube. Thread tapes through the holes in the flanges of the tracheostomy tube and pass them around the neck. Tie them with the neck flexed. The ties should be tight enough to admit no more than a single finger under the tape. Suture the tracheotomy tube to the skin for the first few days until maturation of the tricutaneous tract. For the early complications, we have the infection, tube obstruction, pressure ulcers, and accidental decannulation. For the late complications, we have tracheal stenosis, tracheoinnominate fistula, tracheoesophageal fistula, and tracheocutaneous fistula.